visual fields. Who's this patient who's probably got some neuro-ophthalmic disorders? They are the patients who come to us with sudden visual loss, patients who complain of visual field defect or diplopia or sudden appearance of squint, patients with headache with or without nausea and vomiting, and when we find some evidence of optic nerve dysfunction. In many of these patients, visual acuity is quite poor, and in these patients, we may sometimes have to rely upon some confrontation visual field test, which, when well done, can give us a very good clue to underlying neuro-ophthalmic disorders. In static perimetry, sometimes we need to use larger target size in these patients. Now, how is neuro-ophthalmic field testing and interpretation different from glaucoma fields? Glaucoma fields have been well described by Dr. Manju. Here, for starters, we use the 30-2 CETA program instead of the 24-2 in order to get a little more coverage equally on both basal and temporal sides of the field. Abnormal fields, as interpreted by the computer, may not be abnormal for a neuro-ophthalmic, from a neuro-ophthalmic point of view. Some other points of difference is that here we are first looking for patterns in many cases. So we give a little more importance to the grayscale than we do when we are looking at a glaucomatous field. Fields that respect the vertical meridian are always suspect. Any small adherence to a possible pattern should get your antennae up. First time fields, these in patients may throw up a pattern which disappears when you repeat the field. So we have to be very careful about this. Look for consistency in repeated field testing. And finally, nowadays, we are looking for the structure-function relationship by doing, along with the fields, also doing an OCT, specifically looking at the ganglion cell complex in the GCC in the OCT. This GCC and visual field correlation may give a big pointer or sometimes concurrence of diagnosis many times, and sometimes it may help to clinch the diagnosis or even to prognosticate. I will be looking at each of these points with maybe an example or two. So first, let us see. Usually, neuro-ophthalmic fields, we are looking at both the eyes together, and sometimes where the fields do not respect the vertical meridian and where they are monocular, they are altitudinal field defects that we see in non-arthritic ischemic optic neuropathy, blind spot enlargement in disc edema monocular, central sequocentral scotomata, that is the initial stage possibly in toxic, nutritional and hereditary optic neuropathies, non-specific defects which may be seen in optic neuritis and compressive optic neuropathy. In other words, we are looking mainly at pre-chiasmatic lesions of the visual system. This is a diagram which all of us are quite familiar with. Here I will just not waste too much time on this. I'll just go on to say pre-chiasmatic lesions we just spoke about. Chiasmatic problems usually are looking at temporal field defects, bitemporal, or in some way or the other temporal field is involved. Retrochiasmatic defects, we are looking at homonymous defects which may be congruous or incongruous depending upon where the lesion is. One special situation which I would like to mention is this monocular temporal crescent syndrome. That is, this is an area of the field which is beyond the binocular field of vision, that is from beyond the 60 degrees, mainly between 60 and 90. This is a field that is seen only monocularly by each eye, and a lesion in the anterior medial striate cortex will cause a temporal crescent visual field defect in the opposite side. Usually these fields are best detected by kinetic perimetry or by a full field program in the octopus fields. A 30-2 or a 24-2 will completely miss out this kind of field. So this is a field in a retrochiasmal lesion, a monocular field effect. This is the one situation we should be aware of. Now we just heard Dr. Rajiv Jaydevan telling us that these patterns, our human brain looks at patterns, and that these pattern beliefs may not always be very, very correct. However, in interpreting neuro-ophthalmic fields, any small adherence to a positive pattern should get our antennae up. For example, this was a lady who came to us with a 2-day history of a field defect in her left eye. And so when we did the field examination, we found a superior temporal field defect in her left eye, and a possible evolving defect in the right eye too. So was this a bitemporal defect? So when we did an MRI, it turned out to be a pituitary macroadenoma. So any small pattern has to get our antennae up. This was a patient with a known case of pituitary macroadenoma, which I had been following up since 2019. The fields had remained normal till date, and this year when she came for her routine evaluation, we found a field defect in the left eye, in the inferior, temporal quadrant, temporal field defect. And on doing the OCT, we found that there was a thinning of the ganglion cell complex GCC on the nasal side, which correlated with the field effect in the left eye. This in itself is enough for us to advise perhaps the decision to operate has to be taken for this patient now. Also, in addition, we find that in the other eye also there is a GCC thinning on the nasal side. Perhaps it is a bitemporal field defect in making, in evolution. So this made the decision to operate easier. That is, it reinforced the decision. The patient did undergo surgery after this examination. The second point that I had mentioned earlier was that first-time fields may throw up a pattern. We are now looking at patterns for neuro-ophthalmic patients. The first-time field may throw up a pattern, but this pattern may disappear on repeat field testing because of the learning curve that the patient is undergoing. So we have to be very careful, put the whole clinical scenario together, and maybe look for consistency in repeated field testing. For example, this was a patient with headache who was diagnosed by a neurologist as having migraine, and he was sent for ocular evaluation. He was a myope. His visual acuity, best corrected visual acuity was normal. On doing the fields, we found this scotoma in the inferior temporal quadrant in the left eye. And on looking at the right eye, there was a small question. Is this what we are seeing in the right eye fields? Is this a rim artifact, or is it a developing homonymous field defect? So because it did not fall into the whole clinical picture, we repeated the fields the next day, and the fields were completely normal. So the diagnosis remained as migraine. The patient is just being kept under observation. Maybe we will repeat the fields after the duration. The next point I was talking about is this correlation between the ganglion cell complex of the OCT and visual field, that is the structure function relationship. Here is a case of bilateral sequential NAION. The patient came to us with sudden fall in the visual acuity in the right eye, and he already had a poor visual acuity in the other eye. We looked at the fields and found an inferior altitudinal field effect in the right eye, which was correlating with the thinning of the GCC, superior thinning of the ganglion cell complex in that eye. And the other eye, the acuity was so poor that he could not do the fields at all, and that eye showed a global thinning of the GCC. Another example of the same diagnosis, that is NAION on the right eye, showing a sectoral pallor of the disc. I'm sorry, I don't have the photograph. Showed an inferonasal field defect in the eye. Correspondingly, there was a supero-temporal thinning of the GCC. This was another such patient, sudden drop in vision on the right eye with the fields and the GCC. The poorer vision eye with old history of optic neuritis and optic atrophy showed that is the left eye. The left eye is showing a general reduction in sensitivity and a global thinning of the GCC, and the right eye showing a nasal field defect and a temporal GCC thinning. This was coming to the prognostication that we can make by putting the fields and the GCC together. This was the patient I had mentioned a little earlier, the one who turned out to be to have a pituitary macroadenoma, having come to us with a 2-day history of defective fields in the left eye. So in that patient, on day 1 when we did the OCT, the GCC was normal in both eyes, and so we were able to tell the patient that perhaps after surgery the fields may recover. So she did undergo surgery, and when she came back 2 months after surgery to us, her visual fields had completely recovered. So this way, sometimes GCC helps us in prognostication. This was a patient who came to us with complaints of defective vision in both eyes of very short duration. And these were the fields we thought. Initially, I thought maybe that it is a bilateral lateral geniculate body lesion. And so we did an MRI and followed by an MRI, which were normal. And so I went on to do a VEP, which was also normal in both eyes. And so the diagnosis was finally functional. So sometimes when you do the fields, you have to be careful also that it may be functional. Thank you for your patience.